Mary Pat Ryder, spelled Reiter, was evaluated in the emergency department at St. Peter's University Hospital on June 26, 2017 period. Patient was evaluated by Dr. Borislav, B-O-R-I-S-L-A-V, Stoev, S-T-O-E-V, period. Patient reports that she was riding her bicycle and a van hit her in the middle of an intersection, period. She reports that she was wearing a helmet and she denied loss of consciousness, period. She complained of pain in her left knee and her left shin, period. Evaluation in the emergency department demonstrated she had a closed fibula fracture, an abrasion, and a contusion to her left leg, period. It was recommended that the patient be weight-bearing as tolerated, she was provided with crutches, pain medications, and given instructions to follow up with me as an outpatient, period. New paragraph. My initial evaluation. New paragraph. I evaluated the patient on July 10th, 2017 at my previous practice in East Brunswick, New Jersey, period. The patient reports that she was crossing a street on her bicycle on June 26, 2017, and she was struck by a motor vehicle, period. She reports that she had improvement in her pain, but she was still walking with crutches, period. She said due to the bruising, she was elevating the leg and applying ice, but this causes some discomfort, period. She rated the pain a 6 out of 10, period. It improved with rest, period. New paragraph, past medical history, no illnesses. Past surgical history includes an upper endoscopy, colonoscopy, and wisdom teeth extraction, period. New paragraph, allergies, no known drug allergies. New paragraph, physical examination, new paragraph. This is a well-developed, well-nourished female in no acute distress, period. She's awake, alert, and oriented, period. She ambulates with an antalgic gait using crutches, period. Evaluation of the left lower extremity demonstrates significant contusions and ecchymosis in the left thigh, the left calf, and the medial side of the left foot and ankle, period. She had tenderness over the fibula and areas of ecchymosis on the medial side of the leg, period. Examination of the knee demonstrated no instability with provocative testing of the knee, period. She had weakness due to guarding at the level of the ankle, period. Sensation was intact to light touch distally, period, with the exception of an area of medial numbness in the middle part of the leg, period. New paragraph, I reviewed x-rays from St. Peter's University Hospital, which demonstrated a minimally displaced fibula fracture involving the upper one-third of the fibula, period. There's no evidence of syndesmotic widening, period. The ankle mortise was congruent, period. New paragraph, my assessment was that the patient had a contusion to the left leg and an isolated fibula fracture, period. The contusion involved the leg from the thigh down to the foot, period. There's no evidence of a syndesmotic disruption, period. The patient was fitted with a cam boot, and I instructed her to begin physical therapy, period. New paragraph, the patient returned for a follow-up visit on July 26, 2017. She was continuing to walk with the cam boot and at times at home was able to walk without the cam boot, period. Physical examination demonstrated continued tenderness over the fibula, as well as discomfort with evaluation around the medial side of the ankle and the medial side of the knee, period. New paragraph. Patient returned for a follow-up examination on August 24th, 2017. The patient reported that the pain is mostly on the medial side of the leg above the ankle period. She had minimal pain over the fibula period. Physical examination demonstrated no tenderness over the fibula period. She had tenderness on the medial side of the leg and bruising in this area period. In the right calf, there was an area of resolving hematoma period. Radiographs were obtained which demonstrate the fibula fracture to be healed period. I recommended continued physical therapy and cleared her to ride a bike period. New paragraph. On follow-up examination on September 20th, 2017, the patient reported that she still had clicking in her knees when she goes up steps period. The swelling around her leg seemed to be improved and she had minimal pain around the fibula fracture period. On physical examination, she had minimal tenderness over the bilateral legs period. She did have atrophy noted at the bilateral vastus medialis obliquus period. There was no evidence of a knee effusion period. At this visit, it was recommended continuing to do therapy exercises and focus on VMO strengthening period. She was otherwise cleared to return to work without restrictions period. New paragraph. The patient had an appointment with Dr. Charles Gatt, G-A-T-T, who evaluated her on October 15th, 2018 period. She reported to Dr. Gatt that she continued to have pain in her proximal lateral leg period. Dr. Gatt diagnosed her with chronic instability of the left knee, and he recommended trying a course of formal physical therapy for her knee and her ankle period. New paragraph. The patient returned to me for evaluation on February 26, 2019 period. The patient reported to me that she saw Dr. Gatt because she continued to have pain in her left leg period. She says she started physical therapy, which helped, but she also has been experiencing pain in her hip period. She says sometimes she was having trouble sleeping due to the pain in her leg period. She reported that prior to the accident, she never had pain in her leg, her knee, or her hip period. She says that this discomfort and clicking in her knee, as well as pain overnight, all started following the accident she sustained when she was struck by a motor vehicle on June 26, 2017 period. She reports that she has popping, particularly when she goes up and down stairs on the outside of her left knee period. She also reports that she did have an MRI in 2007 following a baseball accident, and that MRI was normal period. On physical examination, the patient continued to have an area of numbness in the area of the medial malleolus on the left lower extremity and tenderness over the proximal lateral fibula period. She had lateral and medial joint line tenderness in the knee period, no evidence of knee effusion period, positive McMurray's test period, no evidence of varus or valgus instability, Lachman, Lachman, apostrophe S, examination was negative period. New paragraph. I reviewed the x-rays from University Orthopedics. These are full-length tibia and fibula x-rays, which demonstrate no obvious bone fracture, the fibula fracture appears to be healed, and the knee joint is congruent, period. Since the patient was still having mechanical symptoms in the knee, I discussed with the patient my recommendation would be to obtain an MRI of her knee, period. She said she plans to return to see Dr. Gatt in University Orthopedics to proceed with continued orthopedic management, period. Final diagnosis, number 1, is a closed, minimally displaced fracture of the left fibula. Number 2 is a contusion to the left leg, including the knee and the medial side of the ankle, period. Number 3, sensory nerve damage with numbness in the saphenous nerve distribution at the level of the ankle where the patient had a hematoma. Number 4, traumatic arthropathy of the left knee. New paragraph, permanency, comma, prognosis, comma, and recommendations, new paragraph. The following opinions and all of the opinions in this report are of reasonable